The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So as Elizabeth mentioned, my name is Raja Chinthamundeedi and I'm from the University of Queensland, and I'm just going to be talking about a study we did which looked at the effectiveness of modification of medical emergency team activation criteria. But before I start, I'd just like to thank the conference organisers for giving me this wonderful opportunity to talk in front of such a qualified audience and individuals who have been stalwarts in this area of research for over the last decade. Well, at least most people here would believe that the ability of MET calls to prevent in-hospital cardiac arrests, unplanned ICU admissions and unexpected death is quite well established. And compared to the previously used dichotomized criteria, the use of two-tiered and multi-tiered rapid response systems, which allow for clinical review, has improved patient monitoring. Additionally, implementation of the early warning scores have facilitated careful monitoring and earlier detection of high-risk patients for MET activation. Now, patient deterioration has been previously shown to precede MET activation in up to 80% of cases. Therefore, early detection and subsequent intervention reduces the risk of deterioration to a condition which requires MET activation. Now, criteria triggering modifications is quite common practice in hospitals across Australia and New Zealand. They mainly occur to adapt to individuals with chronic physiology or physiological variability due to lack of uniformity between currently used early warning scores and due to the low sensitivity and specificity of the objective trigger criteria. Now, the overarching principle of modifications is to attempt to reduce the false positives that's caused by what's considered to be overly sensitive activation criteria. However, this is unvalidated and currently just a theoretical benefit. However, it is possible that modifications of trigger criteria may in fact lead to delays in MET activation. Now, the first major document to address the criteria modifications was the National Safety and Quality Health Service Standard 9, which related to recognising and responding to clinical deterioration in acute healthcare. It states that trigger criteria requiring escalation of patient care for individual patients can be modified by clinicians. Now, since then, state and local guidelines have been published and incorporate certain principles, allowing for modifications only in exceptional circumstances with sound justification by a medical officer in consultation with a consultant and with documented rationale plus timeframes for review. Now, the Western Australia and New South Wales guidelines were those referenced by the Joint Position Statement on Rapid Response Systems by ANZICS and the College of Intensive Care Medicine. This statement was only published in November last year and conceived that modifications are a necessary part of a working rapid response system. However, guidelines surrounding these modifications are yet to be validated because incidents of MET activation and impacts on patient safety following modifications have never been studied. Upon personal review of the literature, the only study that I came across that looked at modifications on rapid response systems was the 2015 study by Flaboris and others, which suggested that modifications may erode compliance and efficacy of the multi-tiered rapid response system implemented in their hospital. Now, delays in MET activation have been widely shown to independently increase patient mortality. And while the effectiveness of medical emergency teams in reducing adverse events has been widely studied, the impact of criteria modification on MET activation and delaying treatment on the wards is yet to be investigated. Therefore, potential problems arising from criteria modifications and the subsequent failure to initiate MET calls required further investigation. Now, our study had a number of aims. The primary aims were to determine whether modification of MET activation criteria is useful in preventing MET calls at all. We also want to determine whether delays in MET activation caused by these modifications would increase the number of adverse events. Now, we define adverse events as delayed treatment on the wards, unplanned ICU admissions, and unexpected death. We also want to determine the frequency of MET calls and MET call modifications, as well as differences in outcomes between medical and surgical patients. We conducted our study at St Vincent's Private Hospital, Toowoomba, which is a 180-bed regional hospital with a 6-bed Level 2 intensive care unit. We obtained ethics approval from St Vincent's Health and Aged Care Human Research and Ethics Committee and continued to do a prospective chart audit. And this audit was conducted on all hospital inpatients admitted during the 6-month study period with met criteria modifications who also fulfilled our inclusion and exclusion criteria. Now, details pertaining to the patients and their MET calls were recorded on the hospital standard MET form, and to avoid changes in clinical behaviour associated with MET activation and the modifications, only those directly involved in the study were informed of the use of medical files. Now, the data we collected itself, to compare our results to the baseline hospital rates, we collected total hospital MET calls and admissions. And for patient-specific data, we used MET forms, patient observation charts, and patient charts themselves. The data specifically that we obtained was which criteria was modified and whether the modified criteria was met, as well as the incidence of MET activation and adverse events. We also collected whether patients were surgical or medical to allow for comparison between the groups. Now, up here, I've just put up a few of the pages of our patient observation chart and MET form. On the left-hand most side is the St Vincent's Hospital MET form, upon which modifications can be written, and down the bottom there you can see the review date and review time. Now, in this hospital, it's up to the clinician, based on the need of the patient, to write the times of the clinical review. The middle page has written the MET activation criteria as well as the criteria for clinical review, and on the right-hand side is the back page, and on this, any interventions performed on patients following physiological derangement, they must be recorded on this form. For the statistical analysis, we use Microsoft Excel and de-identify the data prior to the analysis, and as most of our data was proportions, we use descriptive statistics, specifically chi-squared tests and Fisher-Exact tests, and anything with a p-value of less than 0.05 was considered statistically significant. So our first set of data relates to rates of MET activation and compares rates in our population with hospital baseline rates. So amongst the 92 patients in our study with MET criteria modifications, 8 had MET activations. This compares to 72 patients with MET activations of the 7,912 hospital admissions during that study period. Now, what this shows was a significant difference between the rates of activation, and whilst it's possible to believe that the modifications themselves may have led to that increased rate of activation, a more reasonable explanation for this difference is that the population for whom MET modification is considered are often at higher risk of clinical deterioration and higher risk of MET activation. Because even with MET modifications in place to reduce the incidence of MET activation, the rate was significantly higher in our population when compared to hospital rates. The data pertaining to the modifications themselves shows there was 114 modifications in total made to those 92 patients. The most commonly modified criteria was oxygen saturation, systolic blood pressure, and heart rate. And of the 8 MET calls activated, only 6 had low oxygen saturation and 2 were called due to low systolic blood pressure. Now, this slide shows perhaps the most significant findings of our study. So whilst there was only 8 MET calls activated for the 92 patients with modifications, there were in fact 28 adverse events. So of the 92 patients with modifications, 28 patients met their modified criteria parameters. So that's 30.4% of patients in our study, and of that 30.4%, 92.9% had an adverse event. That is, 26 of the 28 patients who met their modified criteria parameters had an adverse event. This compares to only 2 out of the 64 patients who did not meet their criteria to have an adverse event. Now, some patients had more than one adverse event. So of those 26, there was 1 unexpected death, 21 delays in treatment, and 9 unplanned ICU admissions. Of the 2 adverse events in the group on the right, they were also unplanned ICU admissions once the patient had started to deteriorate in a sepsis sort of picture. And so comparison between the groups shows that it's significantly more likely that a patient would have an adverse event if they met their modified criteria parameters. So this suggests that a delay in MET activation caused by the criteria modification may have resulted in the greater incidence of adverse events, and this would remain consistent with previous literature showing that delays in MET activation cause poorer patient outcomes. In fact, Chen and others show that only 15 minutes of delay was associated independently with an increased rate of patient mortality and unplanned ICU admissions. So overall, the high proportion of adverse events in this subgroup questions the use of modifications in these patients whatsoever. Now, when comparing medical and surgical patients, there was no significant difference between the rate of MET activation between the two. There was, however, a significantly higher rate of adverse events in medical patients when compared to surgical patients. Now, we have attributed this difference to likely differences in population characteristics. Typically, we notice that the medical patients with modifications had chronic disease states, and these patients were more likely to deteriorate. Whilst for surgical patients, the majority of the modifications occurred post-operatively, and these patients were more likely to return back to their baseline physiology. Now, there are a number of important limitations to consider in our study. Firstly, the conclusions drawn are limited by the small sample size, but also the study was unable to comprehensively examine the clinical culture associated with MET activation criteria and other associated factors. Now, this is particularly important given the variability of rapid response systems used around the country and in New Zealand. So whilst the results apply to the clinical behaviour in our system, their applicability of our data across systems remains somewhat limited. And finally, the key findings from this study must be further investigated in larger healthcare centres. We've extended our analysis for a further 6 months and are hoping to move this study onto a bigger centre within Toowoomba. Now, the conclusions of our study. So the prevalence and incidence of modification has been previously documented in the 2015 study I mentioned earlier by Flaboris and others. But this is the first study to directly investigate the impact of modifications on MET activation criteria and patient care. So the results suggest that whilst there may be benefit of modifications in preventing unrequired MET activation, widespread use may lead to an increase in adverse patient outcomes. And this increase appears to be more likely in medical patients when compared to surgical patients. So overall, the results suggest that modifications may impair the efficacy of the currently implemented framework for detecting and responding to the clinically deteriorating patient, which is consistent with the aforementioned study by Flaboris and others, as well as the recent joint position statement. Additionally, a need for change in clinical behaviour regarding MET criteria modification may be required. At St Vincent's Private Hospital, the clinician writes the time for review when they believe it is clinically appropriate. However, in Queensland Health since September of last year, any temporary modifications to the criteria require review every 2 hours. And this might obviously increase the workload and be very cost ineffective. Therefore, consideration of the clinical behaviour is extremely important because within different rapid response systems in different health jurisdictions, clinical behaviour may significantly improve or reduce the efficacy of responding to clinically deteriorating patients. And overall, this propounds the need for studies with larger populations and a wider case mix to direct clinical practice regarding modification of MET activation criteria and its associated outcomes. I'd just like to thank a few people, Dr. Meher Chinthamundeedi for coordinating the study between St Vincent's and UQ, Dr. Sandeep Faltner for aiding me in the data collection process, and Dr. Ben Chung for supervising the study, as well as the UQ Clinical School in Toowoomba. Thank you.